Okay, now in this last video, we're going to try to put it all together, all the things that we talked about. And we started off with defining what clinical reasoning is. And it is the process where you go from a patient who has a complaint with some symptoms and some signs, meaning they have some subjective and some objective things that you can get from your history and physical, all the way down to making a diagnosis and then eventually a treatment plan. And clinical reasoning is a cycle that we kind of go through over and over and over again. We're going to gather data, organize and interpret it, make hypotheses or a differential diagnosis, test those hypotheses, and we will either rule in or rule out some of those diagnoses that are on our differential, or we won't have enough information. We need to gather more data and re-enter the cycle and go around and around again. And this is how we depicted it here, right? So you're going to acquire data, interpret, organize, make hypotheses, and test it. And when you test it, we talked about those thresholds before. If you were underneath the testing threshold, you could throw away that diagnosis. We are not going to need it anymore. We have ruled it out. If we were above the treatment threshold, then we've ruled it in, we've confirmed it, we don't have to do any more further testing, and we can start treating it. But if we were in between those two, then we were still uncertain, and we needed more information, and we need to test it further. And so then we get some more information, and some more information we can get can come from the history and the physical. Again, we acquire data, interpret and organize it, like by making problem statements. We make hypotheses, what is our differential diagnosis, and then we test those hypotheses again using, how likely it matches an illness script, perhaps, right? And again, we're going to say if we are below our testing threshold, we trash it, right? We rule out that diagnosis. We don't need it. If we are above the treatment threshold, then we're going to treat it. We are going to keep that one. We have ruled it in. But for all the other diagnoses, we need to get more information. Then we need to do diagnostic testing. And so now, again, you have to know which tests to order, which x-rays, which blood tests, and then you got to look at those and interpret them in light of your patient, right? Because of test, you cannot interpret it in a vacuum. You have to interpret in this patient. And then you make hypotheses and you test those hypotheses. And again, we either trash it, treat it, or need to get more data in order to make a diagnosis. And we keep going through this process till we have eliminated all the bad, scary things. We've ruled out all the bad things that it could be. And we've ruled in something to the point that we feel like we can start treatment on that patient. So, right, we started off with all of our book knowledge about diseases. And we put those in the illness scripts, right? And also in the illness script goes all the information from past patients that you've seen before. So your illness scripts grow with you over time, over the decades. Your illness script, you're going to be able to, at some point, just recognize a patient that comes in with a kidney stone just by looking at them. And you could smell somebody in DKA because you're going to have all that history with you. But you also need to know all the book knowledge about it as well. You combine that and you compare that with the problem representation from the patient, right? And that includes all of the data that we get from them, right? And usually the history and the physical. And then we combine those two things together and we get diagnosis and treatment, right? So again, here's this depiction. We have our illness script for a disease, and we compare that to the problem representation, which we get from a patient. And I wrote illness script here. It's really not an illness script, but I wrote that because I want to emphasize that we structure it in kind of the same way, right? The epidemiology, time course, signs and symptoms, diagnostics, etc. And the greater the match, the higher the probability is here, right? And we talked before about key features and differentiating features and rejecting features. And if something has a rejecting feature, that means this will never occur with that disease, then it's going to be very unlikely. And if it has a key feature, what we call pathognomic, that means this is a defining feature that when they have this, we say they have this disease, then it's going to be very likely, right? But real patient care is messy. They may have some key features and some rejecting features, and you're like, what do I do with that? And that's why clinical reasoning is an art. Okay, how do you make your differential diagnosis? Which diagnoses do you call upon illness scripts for? And so there's lots of different ways to do it. You could think of what are the most probable things that somebody with this kind of complaint would present with. what are the must not miss things? Like if somebody who presents with this and I sent them home, what are the dangerous things that it could be? I got to make sure it's not going to be anything that kills them. You could use all kinds of tricks like mnemonics and lists, anatomic and physiologic frameworks as well. And like I said, pattern recognition is one of the ways to build a differential as well. But usually you need to have some experience to be able to recognize these. You have to have seen like hundreds of patients that are similar to this so you can start seeing those patterns and making those connections in your head. I bring it up here because when you are working with clinicians, it may seem like they are not doing any of this stuff and they're just picking a diagnosis off the top of their head, and they probably are, but it's because they have developed years and years of a pattern library in their head, so they can quickly recognize some of these diagnoses. Okay, so for each diagnosis that we have, depending on its probability, right, and we get that by how well it matches with its illness script. And we need to raise this probability either above the treatment threshold, at which point we accept it and we've ruled it in, or below the testing threshold, at which point we have ruled it out and we reject it. And so we need to move all the diagnoses into one of these two categories. Hopefully one of them rises to the top because the patient only has one disease, and the rest of them go under the testing threshold. And we know that we're going to set the testing thresholds and treatment thresholds at different places for different diseases, right? In this case, we're more likely to test and less likely to treat because perhaps the treatment is costly in some way. Maybe it's dangerous. Maybe it has lots of side effects. And in this case, maybe the treatment is safe, so we are more likely to treat and less likely to test. Similarly, for the testing threshold, right? We can raise the testing threshold when testing is expensive or dangerous, and doing nothing is inconsequential, right? Because that's what the testing threshold, this little red area, means. It means that we are discarding this diagnosis. So if I'm wrong, what is the cost of me being wrong, right? What if it's a headache and it's a tension headache? It's not a big deal. You're not going to die from a tension headache. However, if it's a disease that is dangerous, that could kill you, what if it's meningitis, which could kill you if your headache is from that? I got to be really, really sure that it's not that. So I want to lower this threshold so that I am going to make this space as small as possible, meaning I am going to be very much more sure that you don't have the disease before I send you home. Okay, so we start with a pretest probability, and then we do a test, right? Because a test is what's going to then get us from this green area to either the blue area or to the red area. And positive tests are going to raise our probabilities, and negative tests are going to lower them. And how much it raises them or how much it lowers them depends on the test characteristic. A very specific test is going to raise the probability more than a less specific test. And a very sensitive test is going to lower the probability much less than a low sensitivity test. And we remember here, SpPin and SnNout. A high specific test, when it's positive, helps you rule something in, right? High specific, when positive, helps you rule it in, as opposed to one that's got low specificity. And similarly, a high sensitivity test, when negative, helps you rule something out. So this one is a high sensitivity test, when negative, is going to help you rule it out, as compared to this one, which has low sensitivity. The 2x2 table you're going to see probably on board exams, and so understand this, and so that's why I put it here again. The diseased and healthy is on the vertical, and on the horizontal are going to be the test state, positive or negative. And really, we talked about many different ways of going from pre-test to post-test probabilities. I think the likelihood ratios are perhaps the ones that are the most in vogue now, and so we can calculate those using the sensitivity and specificity, then use something like this Fagan nomogram in order to calculate a post-test probability. But we did see there were other ways to do it, right? We were able to use a 2x2 table to do it, or we did some, ratios with those Bayesian reasoning boxes as well. And pretest probability matters. That's the other point I think that is important, right? If you have a low pretest probability, a positive test may not help you that much, right? Because you thought it was so rare to begin with, and then you do a test on it, and the test is positive, it's probably more likely that the test is wrong than it is that it's right. Right? And so it's not going to perhaps get you out of this red zone. And as you have higher pretest probabilities, then it's going, the post-test probability is going to be higher. A test is going to help you more. And the converse is true as well. If you have a high suspicion for something and you get a test and it's negative, you're not going to say, it's not that. You're going to say, no, my suspicion was high to begin with. My spidey sense is tingling. I still think it's that disease, even though that test it says that it's not. Because as we know, no test is perfect. Okay, that was our clinical reasoning in a nutshell, and we'll perhaps go through some examples during your classes. If you have any questions, please let us know, and thank you guys for watching.